Hello, everyone. My name's John McDonough from the Harvard Chan School of Public Health. Welcome to Health or Consequences, the health policy podcast from CommonWealth Magazine and Mass Inc. We do this every month, and my co-host is Dr. Paul Hattis, formerly of the Tufts University School of Medicine. Welcome, Paul. Great to be with you again.
Thank you, John.
And we started this podcast at the end of 2018, and our very first guest was Mary Lou Sudders, Secretary of Health and Human Services for the Commonwealth of Massachusetts. And we are thrilled and delighted to welcome her back here with us today as our very first guest who's here for the second time. So congratulations on that. Welcome, Secretary Sudders, and thank you very much for joining us. We know you are one of the busiest people in the state of Massachusetts, and we appreciate very much your spending this time with us to talk.
It's my pleasure to be with you. Apparently no one else is willing to come back a second time. Is that what you're saying to me, gentlemen?
No, it took us a long time to get over that threshold that we would let someone back.
Oh,
and we just broke down all the barriers for you.
It took a COVID pandemic, to say the least. We were so incredibly pleased to have you here, and I want to offer my welcome and thank you. As always, in this pandemic, it seems like you and the governor are often making news. So let's start with today's news, where we learned that the governor's adding some additional state requirements to try to reduce the density of human interactions, both inside and outside. And you spoke a bit today about the need for hospitals starting the day after Christmas to end elective inpatient surgery unless patients might be harmed if they delay. So perhaps you can tell us a little bit about those developments and really what's on your mind as a result of the things that you and the governor are doing now.
Yeah. Well, thank you. And again, truly thank you for having me. It's hard to imagine. We've been in this pandemic for, really almost a year now. Certainly March is when we sort of formally stood up the command center. But one of the things that this pandemic evolves, and what we experienced in the springtime is very different from what we're experiencing now. We have to protect our healthcare system in the sense of having the ability to meet whatever comes to us. The great news about being in Massachusetts, and I know Paul, you and John know this, is it is a strong healthcare system. We can have the debates about cost, and of course we can always do better when it comes to availability and equity issues, but we start from a strong base, but we need to protect that base. We need to make sure that we never have to implement crisis standards of care, or we have people who come to an emergency department that you just can't manage and take care of. So unfortunately, one of the things we've seen since Thanksgiving is we saw a doubling of admissions and positive COVID cases. And that really worried us. And despite all of our messaging and pleas and, increasing things like the mask order and nighttime advisories, everything closes at 9:30, 10. We continued after Thanksgiving. We saw this rapid increase. And as we come into a very major holiday time, we felt that we needed to take additional measures to reduce the transmission, to keep our healthcare systems able to respond to whatever acute care needs come to us, and to send a strong message to all of us that we know we're tired, we're weary of COVID, we have hope of vaccines, but we need to bridge to get through the holidays. And today's measures, the CDC, we know that reducing capacity is a good tool, and basically across the board. There's very few things, and we went from 40% capacity to 25% capacity, pretty much across the board. Very few things are exempted to try to not see the doubling of admissions in our hospital systems through the holidays. We had curtailed elective procedures, inpatient elective procedures, and felt that we needed to take that next step. Of course, clinical decision is what needs to really prevail. And this is not like the spring where we closed, healthcare essentially, except for COVID. Outpatient is open, ambulatory is available. We want people to get those very important preventive services, but we need to make sure we have the inpatient capacity to meet whatever the demand is. And honestly, I hope we don't have the demand, but we need to be prepared for it.
And there's a new variant that is alarming people around the world from Great Britain. Apparently, it's been in Britain since September and has become very widespread. Do you assume that that variant is now present in the United States and in Massachusetts? Do you not know? What's your assessment of that at this point from your expert advisors?
Yeah. So we don't know. We don't have certainty. But that's one thing about a pandemic I think we've all learned is that a pandemic continues to evolve, and it's a global pandemic, John. And I think one of the things we all know from now, right, hindsight being so helpful, is what a lot of people wanted to characterize, that the disease, the virus, came from China. Yes, the virus came from China, but the virus came from Europe and from the Middle East. And so I have people watching with the CDC what's happening in Europe and in Great Britain to advise us. Now, what we have heard is that both Moderna and Pfizer believe that their vaccine is effective to this mutant virus. So that is the good news I've heard. But we have to be very present, not just what's happening in Massachusetts and in our country, but also what's happening to the pandemic globally. Because if once we're on the other side of this pandemic, I do hope that all of us realize truly how very small the world is and how fast a virus can spread across the world.
And how are you assessing at this point the vaccine rollout? Are you satisfied, pleased, concerned, worried? What category do you fit in as you look at the rollout over the past couple of weeks and looking ahead with what you know?
Well, I'm a worrier, so I always worry. It's just my personality type. I have hope, truly. For the first time since the beginning, I actually have some hope. The initial, the federal government buying Pfizer, all the Pfizer, Moderna, means that we're sort of dependent upon working closely with the federal government on the allocation. We actually tried in Massachusetts to get sort of a position in with Pfizer, Moderna, and we were informed that the federal government had basically bought all the vaccine and had first order refusal. So that was one. Initially, we were concerned about how the federal government was going to allocate the vaccine to across the country. Initially, we were hearing, complicated formulas, and our belief, the governor and mine, when I met with Project Warp Speed with the Department of Public Health right around the election, our position was per capita. I mean, across the country, it had to be a per capita allocation. Nothing more would be fair, right? I could argue that we were hit hard early and the Northeast should get more of an allocation, but a per capita allocation. And the federal government agreed with that. The announcement about what we could expect in the beginning in the month of December, the Pfizer allocation, what we first heard, so the 59,000 that we thought we'd get every week was then reduced. That causes anxiety. Like what was behind it. I appreciate General Perna, who I think is a straight shooter. He said it was a mistake. I can accept that because this is this is the beginning of a rollout of a vaccine. We're going to be vaccinating, we have 6.9 million people. If you think individuals over the age of 14, 16, that's about 5.86 million people. We're going to have our own lumpy bumpy moments in rolling out the vaccine. So this is the beginning, and I look forward to the day when we have so much supply, it's everywhere.
So, Secretary, your advisory committee, worked very hard with you to come up with a prioritization scheme for vaccination. And while there seems to be universal agreement that the COVID-facing frontline healthcare workers and nursing home residents and staff are the top, in recent days, the CDC has put something out suggesting that maybe people over 75 ought to potentially stand in line next, even relative to some of the categories of essential workers. So I don't know if you have any thought about that or any reshaping of our own prioritization in our state.
Well, I'm one of the best recommendations I think I did make was to establish a vaccine advisory board to help the Department of Public Health think through the prioritization, understanding that as we rolled out vaccines, there wouldn't be enough, for everyone in the state. And they very much, Paul, used the AHIP and the NASEM's blueprints, guidelines, but we made some adjustments in Massachusetts. The two big ones we made, or they recommend, three that they recommended. One was COVID-facing healthcare and non-COVID facing healthcare workers, right? So they made this sort of distinction. And in doing so, they defined healthcare workers to include dietary, environmental services staff and the like, if they were COVID facing. That was a bit of an equity lens. And the second modification they made to the federal guidelines was moved home healthcare workers earlier in the prioritization. That again was an equity lens because, as you know, we have 40,000 personal care attendants, we have a lot of home health aides, and they are disproportionately individuals of color. The third thing, I think the advisory group, their priorities, their three main goals. One was obviously preservation of the healthcare system. Second was to reduce the mortality. And the third was equity. And you see equity in the advisory board's recommendations around this sort of 20% allocation to those communities that are disproportionately impacted. And we will be putting up a dashboard so everyone can see the data. So what we've done is we've asked the advisory board to come back, and they're meeting tomorrow, to look at these new recommendations and to advise us as to whether we should make modifications. We feel very strongly that equity needs to be very much part of our allocation methodology. So that's why you put together advisors who are a lot smarter than you are and had very different backgrounds, as I know you know, to advise us. So, and we will make that public.
Just staying with COVID for a few more questions. The nursing home sector has really been one of the big epicenters of it in Massachusetts and around the country, and very much in Massachusetts. How do you assess the progress that's been made in terms of addressing the threat of the pandemic in the long-term care and nursing home sector? And how do you feel about where we are right now on that?
There's no question, residents, that COVID has had a devastating impact on residents of nursing homes, their loved ones, their staff. It's about 65%. In the spring was about 65% of all of our deaths were related to long-term care. It hit hard, it hit fast. The asymptomatic spread of the virus, the fact that testing was so limited in those days. These are not excuses, it's just sort of, February 28th, we had zero capacity to do any testing in Massachusetts. And as testing started to ramp up, the CDC guidelines, and honestly, looking back, like one of the great regrets or mistakes is that you only tested symptomatic individuals and only residents in nursing homes. In April, we ramped up testing, and we actually deviated from the CDC and tested staff and residents, and then had one of those aha moments when we were creating COVID facilities, COVID nursing homes, and tested all the residents. This is Avinia up in Wilmington, of which they'd had no cases, and went to just do surveillance testing, and half of the residents tested positive. That was truly one of those moments. And when I say aha, it was like a shock. And that really forced us to, one, really rethink who got tested, how you cohort, and the like. We put in, we've spent almost $400 million in rates and accountability. So it was accountability with money. So financial incentives and accountability. We put in our own surveying, because it was clear to us that the CMS surveying was not sufficient on infection control. We've put in our own measures around hours per patient day. It's never been a standard in Massachusetts. So we now require above the 5-star standard, hours per patient day. So through April, through the summer, we tied financial incentives with very specific infection control procedures. And we saw infection rates come down significantly in long-term care. Come fall, right, we see, because of community transmission, even though we have required testing of staff and residents. If there's a positive of either a staff or resident, we require, at state expense, everyone in the facility is tested. We freeze admissions now to nursing homes, and admissions don't reopen for 14 days after a last positive case. I have 22 rapid response teams that literally go into nursing homes that are having staffing issues, infection control issues. A cluster happens, to literally, they are enough of a staffing unit to literally staff a floor. And there are eyes and ears, and it's a combination of the National Guard, which we reactivated this in November, plus a contract we've had with a group since the spring. And one of the best decisions I made was, when we didn't need them this summer, I kept them on a contingency contract in case we needed to increase their hours again. So it's fragile, in all honesty. It is one of the things I worry about most is clusters happening in long-term care, because aside from the devastating impact on residents who are most susceptible, right? Older, maybe with comorbid conditions, not as active. Maybe they have DNRs. They may have, DNHs, do not hospitalize. So if a cluster happens, it takes a good 14 days between testing and cohorting and stabilizing to then have no COVID positive cases in that nursing home. And we have clusters going on right now, and there's about 6 nursing homes on any given day where we have clusters. And it's truly one of the things I worry about the most. I spend every day with a team of people. I have a command center structure on nursing homes up into the command center of all the agencies involved. And they will probably tell you, I'm pretty relentless about it because we need to keep residents safe. We need to provide the supports to their loved one. We close visitation when there's a cluster, which is heartbreaking and anxiety arousing for families who now then can't come in, and they know there's a positive cases of staff or residents. Working very closely with SEIU 1199. In fact, we just had today's Tuesday. I really do know what day it is. It's been like one long day since March. I sponsored with 1199 an open forum about vaccines that we held in English and Spanish last night at 8:00 around vaccines, because we were rolling out vaccine for long-term care. But this is a constant changing, not changing in a bad way, but like oversight. And there's a lot of lessons. We have strong regulations out about the future of long-term care around infection control.
Secretary, we do want to move on to other topics, but before we leave this one thing you haven't mentioned, although you just shared how much learning you had, for example, in the nursing home context during this era, but what's this been like for you personally in the role that you've had thus far? And we're still, as Joe Biden said today, the darkest days are still ahead. So we're not talking about this when it's over, but thus far, what's been it like for you personally to be in the role that you've been doing for COVID in our state?
It's heartbreaking. It's demanding, but I sort of knew that. When you step into the role, you become the lightning rod for hopes and dreams and frustrations, and why are you not testing enough? Why are you do every issue is you are the lightning rod for it. I feel every death. I feel every tragedy that's happened, and work extraordinarily hard with an extraordinary group of people to provide as much data as possible. Always trying to be as transparent as possible about the decisions we're making and why we're making them. And then you have to be open to the criticism and other ways of thinking about it, which I always try to be. But it's been a long journey. A lot of every decision you make, and really incomplete information that came to us in the beginning about this virus. But for the first time, Paul, I truly have hope. And that is from the vaccines that are available. If we can help people believe that they're safe, provide the data. I have Paul Bittinger and a number of doctors out just talking straight to people. And so far, the acceptance rate among healthcare has been quite strong. And we'll see how that continues.
Good to hear.
Mm-hmm. So staying on COVID and moving a little bit beyond it, you're in charge of
there's something other than COVID?
Well, it's related. You're in charge of Mass Health, the largest health program in Massachusetts. And you had this big, bold experiment around accountable care organizations that's been going on for 2.5 years now. What's been the impact on Mass Health, and in particular, the ACO experiment from the pandemic?
Well, I would say that the pandemic definitely slowed lots of things in, government, just because you were focused on the pandemic. But a couple of things about Mass Health and the ACOs. So one is we came out lightning fast on telehealth, Mass Health, ACOs, across the board. And we converted and made the statement that we would pay parity, right? Telehealth, telebehavioral health at the same rates as in person, which was a little concern to some of our friends in the insurance market, but we felt that was very strong. It was in the governor's order. It was in the Mass Health program. And quite frankly, Mass Health set the standard for everybody else. And I feel very good about that. And that was Mass Health pivoting. And we pivoted first in the ACOs, but then across the whole Mass Health book of business. And telehealth is here to stay in the Mass Health program. We just extended, we have to do this through CMS approvals and the like. That is one. Secondly, the flex services part of flexible services, which was part of our ACOs. Thank goodness, honestly, that we focused on housing and food insecurity were the two primary parts of the ACO program. And if ever there was a year to roll out flexible services in a Medicaid program, would be the year of a pandemic, when food insecurity is an extraordinary consequence or heightened as a result of the pandemic, and housing insecurity. So the ACOs, I don't have the data at the top of my head, but the ACOs pivoted really quickly to roll out the flexible services parts of their programs. I actually just spoke to the food insecurity group at their conference that's put on by Community Servings, and they were all talking about how no one could have predicted how important that was as part of the ACOs. At the time we were, you didn't write an 1115 waiver based on you're going to have a pandemic. We have about 1.2 million people continue to be in the ACOs. Believe it or not, we're actually starting to plan for our next waiver. Who knew? Feels like just yesterday I negotiated the last one. Continuing the restructuring into population-based health, the lessons learned from the first one, like what works, what doesn't work quite as well, but continuing the path of restructuring the Mass Health program into a population health model. Second is really working much closer with the correctional facilities, really like trying to move into correctional facilities much broader, much more intensely, if you would, to work with folks so that you don't have medical recidivism. And so when they come out, right, they've gotten their services really lined up, started in prison or the jails, and then into community. And equity lens is also very important to us. So we think it's the right foundation, and we need to make the adjustments going forward. We've started as you know, we love community engagement. So we have started our process of lots of community groups around structure, community partners, flex services, primary care. Where do we pivot? Do we have too many ACOs? So those are all the kinds of things we're going through now. So far, no one has said throw out the model, but we clearly need to tighten up the behavioral health primary care work and the workforce part. So it's a good work in progress.
Yep.
So let me build on, you're talking about the current Medicaid program and where it's going, to talk about some other news of the day, which is the House and Senate have come out, the Joint Healthcare Finance Committee, with sort of the content of its proposed healthcare bill. After many long months of action, especially on the Senate side, a lot of discussion on the House side. But what are your thoughts about what's in that bill and where it goes from here?
So I haven't seen it. I haven't read it yet, but from what I've heard, so first of all, I'm pleased. I'm pleased that the House and Senate have been able to find the path to work from our 96-page blueprint. There's some very good things in it. So telehealth. We have been advocating and working with the legislature that telehealth in the Commonwealth really is predicated on the governor's executive orders. And other than what I can do in the Mass Health program, once the emergency expires, is terminated, so would telehealth. So the fact that the bill that's coming out of conference has telehealth and has telebehavioral health paid for at parity rates, in person, the same as a telehealth visit, continues what we had put into place. Has telehealth for, I think, primary and chronic care. I'm not sure I haven't seen what the definitions are yet. For 2 years is good. And then there's another piece that is for 90 days beyond the governor's executive orders. So in my mind, it really builds on what we had proposed around telehealth. Scope of practice, Paul. It's
letting people work at the top of their license, right? In the full
people working at the top of their license. We That was very much, so telehealth was part of the governor's healthcare bill. Scope of practice was part of the governor's healthcare bill. So we think that is significant movement from our colleagues in the legislature. I think on out of network, they are, I have not seen the language, but what I was reported to me was that on out of network, that they will let, I believe, the Secretary of Health and Human Services to define what that is through regulations. Those were three that I heard. I know there's some things around COVID and payments and the like, which, I will look at.
Something
So
about
those
helping
were like
hospitals.
Community
Hospitals who have high
with a
Medicaid.
cap at 35 million, I think. Yeah. So to me, it has many pieces of, it builds on, what many pieces that we proposed. I haven't seen, other than the telebehavioral health, that there's other things on behavioral health, which is always important to me. But I'm feeling good that they quietly been working together to put out a conference committee, and they started at very different places. So I see this as good progress for this session, and I look forward to taking a hard look at it and and advising the governor and what we should do.
When you say that, you mean the House and the Senate started at different places. Sorry, John.
So, Madam Secretary, we're just about out of time with you. Just have to ask, what are you most looking forward to with the new Biden administration?
Well, one is the new head of the CDC is our own Massachusetts Rochelle Walensky, who I've gotten to know really well through the governor. She's on the governor's medical advisory board, and I had recommended to be on the reopening board. So just to have someone who really understands healthcare and policy and practice up front and close, personal, I think and she's just an extraordinary person from my perspective. At CDC was great. A federal administration and a president who is empathic, who embraces everyone in our country and builds upon the strength of our democracy and acknowledges the diversity of our people, I think is a uniter, is somebody who will unite. The one thing about Joe Biden is he understands grief. He understands, and I don't, but he's taken that grief into a belief of your own belief into what government should do for people. I think it's going to be hard because I think we're clearly, things are very divisive in our country. But I think for me, he believes in science. I think we will have a federal government that we can trust the policies. And as someone who's been in and out of public service my whole life and I am a public servant, that's really important to me.
So, Secretary Sudders, thank you for the amazing, incredible, and most challenging and difficult work you've been doing. Thank you for joining us today, and good luck from both of us and from everybody in the Commonwealth as you continue to help us get through this enormous challenge.
Well, thank you, gentlemen. I hope you stay well, practice bubble fidelity. That's my Christmas wish for happy holidays. And all of us are looking forward to 2020 being over.